Welcome, everyone. My name is Jeff Clough. I'm a faculty member in the Department of Pathology here at St. Jude. I'm pleased to be hosting a special event that we hold each season in the Science of Childhood Cancer lecture series. I'm focused on rising stars of cancer research. These events are designed to highlight innovative research conducted by early and mid-career investigators in pediatric cancer. Today, we're going to be hearing from two rising stars, Dr. Brian Crompton and Dr. Seth Carroll. Each speaker is going to talk for 20 minutes, followed by 5 minutes for questions and answers. If there's any additional questions, both speakers have agreed to stay on after the hour for further questions. Before I introduce our first speaker, I'd like to note that you can ask questions at any time during the talk by using the chat function, and just send those questions to all panelists. And now I'm delighted to introduce Dr. Seth Carroll. Dr. Carroll is currently an associate member here at St. Jude Children's Research Hospital. He performed his residency at Rainbow Babies and Children's Hospital in Cleveland, Ohio, where he was chief resident. This was followed by a pediatric hematology oncology fellowship here at St. Jude, and he stayed on after his fellowship and has really risen through the ranks to his current status as associate member. He's a recipient of a KO8 award and has received the Joseph E. Simone Golden Apple Award for his teaching and mentorship. He's a past and current leader of many leukemia trials here at St. Jude, including the upcoming St. Jude-sponsored trial for newly diagnosed acute lymphoblastic leukemias, as well as APEL 20D, a venetoclax-based study for relapsed refractory AML through LLS. His clinical work on venetoclax and relapsed refractory leukemias also includes the RAVEN trial, and he previously worked on the VEN-AML trial for relapsed refractory AML with Jeff Rubnitz. And he is going to be speaking to us today about novel venetoclax-based combinations for relapsed pediatric leukemias. So with that, I'll turn it over to Dr. Carroll.
Thank you so much, Jeff, for the introduction. So as Jeff introduced me, I'm in the leukemia lymphoma group. A couple of disclosures that I'll show up here, and I'll just note that as a pediatric oncologist, we're going to talk about off-label use of medications as we do every day in our care of patients. So I'll dive right into relapsed AML and just remind the group of how poor these outcomes are, particularly as we get past first relapse. And so we know that 60 to 70% of children with AML will ultimately be cured of their disease, and we may salvage a quarter or a third of patients that relapse the first time. But if you get past that first relapse, your outcomes are really quite poor. And so on the left are data from the BFM group that demonstrate that outcomes with any therapy, be it intensive, less intensive, or palliative care, are quite poor, and projected outcomes for patients receiving treatment are around 20 to 25% if you're in your second relapse or beyond. And unfortunately, although we've made improvements to supportive care and to transplant therapy, as the graphs on the right show, we do not see improvements with time. So the outcomes in the mid-2000s, shown in blue, look the exact same as the outcomes in the late 20-teens, the 2014 to 2017 period, shown in green. And so those other outcomes that we've seen improvements for in other groups are really not replicated in these patients with multiply relapsed AML. And so one reason for that is that cancer cells, as they relapse, become increasingly resistant to chemotherapy. And so the typical strategy to kill cancer cells is provide some cellular stress, typically in the form of chemotherapy, and that activates proapoptotic BH3 family proteins, such as BIM and BID, and these can then activate effector proteins such as BAX and BAC, which can go to the mitochondrial membrane, cause mitochondrial membrane permeabilization, and ultimately cell death. Those effects are opposed by pro-survival BCL2-like proteins, including critically BCL2, BCL-XL, and MCL1. And these counter the effects of these pro-apoptotic proteins and sequester death effectors as a mechanism of cancer survival and cancer chemotherapeutic resistance. And it's been well documented that the relative ratio of BCL2 and its family of proteins to these effector and pro-apoptotic proteins are associated with decreased sensitivity to chemotherapy, cancer cell resistance, and are higher at relapse. And so venetoclax is a first-in-class, novel, orally available, fairly selective or highly selective BCL2 protein that is able to, a BCL2 targeted protein that is able to displace the proapoptotic proteins from BCL2. That allows them to translocate to the mitochondrial membrane and lead to this sequence of events that causes mitochondrial membrane depermeabilization, cytochrome C release, and ultimately activates caspases and causes cancer cell death. And so venetoclax has been extensively studied in both adult and pediatric cancers. As almost all drugs are, it is much farther along in adults. And probably the most critical result relative to pediatric cancer has been this finding that venetoclax in combination with azacitidine resulted in improved overall survival compared to azacitidine monotherapy in adults with AML that were unfit for aggressive chemotherapy. And so that work was led by Dr. Gennardo and was published in 2020 in the New England Journal. But at the time of that publication, there were not studies that were published that suggested that venetoclax could be combined with intensive chemotherapy, which is clearly our strategy of choice in the context of relapsed AML. And so as Dr. Clow mentioned earlier, Jeff Rubnitz designed the VEN-AML trial, which is described here. This was a phase 1 with a dose expansion cohort study that involved venetoclax in combination with standard pediatric AML therapy, including what we would call low-dose cytarabine, which is still about 5-fold higher than adult low-dose cytarabine, as well as high-dose cytarabine. And that was a first-in-children study to look at that higher dose therapy. We also tested it in combination with anthracyclines, which again, critical as we think about moving this forward for AML more broadly. And so it was a 28-day cycle of venetoclax with chemotherapy starting after a 7-day venetoclax window, and the dose levels are shown below. Because it was unclear whether higher doses of venetoclax up to the 600 milligram equivalent would be well tolerated, and it was unclear whether high-dose cytarabine could be tolerated with venetoclax, there were 2 dose level 2s, and then these were effectively combined as dose level 3, with dose level 4 being the addition of the anthracycline. And we were really very excited to see the responses to these therapies. As you can see, we were able to progress through all four dose levels, including both dose level 2s. Patients tolerated each of those dose levels, and we saw responses at every dose level with either a CR or CRI observed at each dose. As you can see, as we got closer into these higher doses of therapy down in dose level 3 and 4, we were seeing improvements in the rates of CR and high rates of MRD negative CR in patients with relapsed, including multiply relapsed and refractory AML. And when we combine all patients in the trial, the overall response rate approached 70%, and patients treated at the recommended phase 2 dose of either dose level 3 or 4, depending on prior anthracycline exposure, had CR and CR rates of 70% and an overall response rate of 80%. And so this was incredibly encouraging in this very heavily pretreated population. I think equally exciting for us, though, is there were hints that we could identify biomarkers of response quite early in therapy. So I mentioned to you that there was a 7-day venetoclax window that began therapy for all patients. And so in the context of that window, we measured blast response. And the way we did that is we measured the white blood cell response and did MRD analyses at both prior to therapy and just prior to the initiation of combination chemotherapy. And then we can determine the total peripheral blast burden and determine how much that blast burden decreased in that 7-day window. And so when we looked at all patients, we really appeared as though about a 50% reduction in blasts. So up here, we have a 100% reduction in blasts. Down here, we have blasts increasing. And that reduction in blasts seen during the 7-day window was highly correlated with the response we got out of the bone marrow at the end of the 1-month cycle of therapy. And so patients that achieved a CR or CRI are shown here with blue squares for the full CRs and CRIs with the blue dots. As you can tell, almost all of them, all but 3 of those patients saw a significant reduction in their blasts in the context of that 7-day window. In contrast, patients that did not respond, shown in the red triangles, or patients with partial responses in the green diamonds, were much less likely to have good responses to the venetoclax. And this response correlated not only with the end of cycle response, but also with things like BH3 profiling, looking at the cellular level at the proteins that seem to be most responsible for chemotherapeutic resistance. And so patients that were BCL2 dependent were much more likely to have a good window response to single agent venetoclax and ultimately to achieve CR, suggesting that a very easy to achieve test and a clinically relevant and actionable test could predict whether patients were likely to respond to venetoclax combination therapy. And we can imagine a world in the future where if this is validated, that you might use this window response to identify patients that should continue on with venetoclax combination therapy versus who should be triaged to alternative salvage regimens. And so we thought that these results were really impressive and really important, and yet there's clearly more work to do with venetoclax in the context of pediatric AML. So the data from adults and from ven-AML really strongly suggested that we might find some benefits in pediatric AML with this drug. But we really need further studies, particularly in the context of regulatory approval. And that's very important for this drug because unlike drugs that come as powders or as liquids that could be injected, there's no pediatric appropriate formulation for venetoclax available right now. And in the context of clinical trials, we can't just take commercially available drug, crush it down and give it to patients, even though there are centers that have done that clinically. And we also acknowledge comments that reviewers have given us and that regulators would give us as well, is that although the ven-AML therapy is clearly active, the backbone there isn't perhaps the most appealing in the context of disease, particularly beyond first relapse. And so to address all of these concerns, the Leukemia and Lymphoma Society's PEDAL initiative worked with AbbVie and developed a randomized phase 3 trial that Jeff referenced earlier called APAL 2020D. And so APAL 2020D is a randomized controlled trial. It's the first randomized trial in relapsed AML, a first global relapse trial since the BFM trial that examined donazole in the context of FLAG chemotherapy. And so the goal of the trial is to randomize 98 patients to a standard of care arm A that includes a FLA plus gemtuzumab backbone versus that same standard of care with venetoclax. And similar to the ven-AML trial, these patients get a 7-day venetoclax window. We are assessing that same window response, just as we did on ven-AML, and we hope to be able to validate that biomarker in the context of this relapse trial. Patients begin their combination chemotherapy on the venetoclax arm at day 8, and all patients are assessed for cycle 1 response at the end of approximately a month from their chemotherapy. Patients who are in remission can proceed to transplant or can alternatively receive a second cycle of either FLA or FLA plus venetoclax chemotherapy. And at the end of 2 cycles, patients should proceed to transplant if able, but if they can't or they require either bridging or maintenance therapy, patients can continue to receive maintenance therapy on trial with either azacitidine on the standard of care arm or azacitidine venetoclax on the experimental arm. This is a stratified randomization that includes primarily patients with second relapse, but we've also allowed patients with first relapse who can't receive additional anthracyclines to receive this therapy, and we stratify them based on timing of relapse. And so in summary for AML, the outcomes from relapsed pediatric AML remain quite poor, but data from both preclinical models and adult data suggest that venetoclax is highly active. That really aligned very well with the ven-AML data that we demonstrated that showed the safety and activity of venetoclax combinations with high-dose chemotherapy in this population, as well as demonstrated that the window response might be an important biomarker and might align with critical biology such as BCL2 dependence in this population. The ongoing APAL 2020D trial is an international label-enabling randomized phase 3 trial of a FLAGO backbone with or without venetoclax in children with relapsed AML. And it's the first trial to come out of the Leukemia and Lymphoma Society's PEDAL initiative and is currently enrolling at St. Jude and other hospitals in the US, Canada, and Europe, and will be coming soon to Israel and Japan. So switching gears to the other relapsed leukemia that we take care of here in pediatrics. So RAVEN is a trial for relapsed pediatric ALL. And the background for this trial really is that MRD negativity and MRD negative remissions are critical to achieve in the context of relapsed pediatric ALL. Data from prior COG and European trials has demonstrated that patients who are able to achieve MRD negativity after their first cycle, shown in the yellow R1 line, have far improved outcomes compared to patients that ultimately take 2 or more cycles to achieve MRD negativity, or patients who can't quite achieve MRD negativity but have persistently decreasing disease in the context of 3 blocks of intensive therapy, shown in blue and gray respectively. Unsurprisingly, patients who progress through chemotherapy, shown in the orange dashed line, have the worst outcomes, and those patients almost universally relapse and die over the course of several years follow-up. Even patients with late first relapse of B-ALL, shown here in blue and red, demonstrate the critical importance of achieving MRD negativity. Patients who are MRD negative at less than 0.01, shown in the blue line, have vastly superior outcomes to patients who do not achieve that threshold after a single cycle of therapy. And this is in the context of standard of care R3 therapy. This is data from that original UCAL R3 trial. And so we know that we need to get these patients MRD negative. Unfortunately, historical data suggests that conventional chemotherapy is inadequate to achieve this level of MRD negative remission in the vast majority of patients. So the UCAL R3 data that I just showed you survival curves for suggests that only 42% of late relapse B-ALLs are able to achieve MRD negative remissions with the first cycle of therapy. Outcomes for patients with early relapse are even worse, with only a quarter of patients becoming MRD negative after a block of therapy. And outcomes beyond first relapse are even worse. There are in fact not good published data on the rates of MRD negative remissions beyond first relapse, but we know that only 40% of patients will ever achieve even a CR in this context. And if we assume that even that data would provide that the late B relapses provide the best possible outcome, we impute that less than 20% of patients will become MRD negative with standard therapy in the context of multiply relapsed or refractory disease. Even with the addition of bortezomib for patients with T-cell ALL, we see that less than 20% of patients are able to become MRD negative after a single cycle, suggesting a clear unmet need in the context of pediatric ALL. We also note that conventional therapy is highly toxic, and review from both the TACL Consortium as well as data from presented in abstract form from AALL 1331 suggest that there are high rates of ICU admissions and high-grade toxicities in the context of R3 therapy, particularly in patients who are either on therapy relapses or who relapse at an older age. Indeed, among the 59 patients treated among this TACL retrospective cohort with R3 therapy, there were 53 documented infections, with over half of those being either bacteremia or fungemia, as well as an episode of meningitis. And there was one treatment-related death. We should actually, although that sounds horrific, and it is, it's actually better than the rates that we're seeing in R3, in which almost 10% of patients treated on the now standard of care mitoxantrone arm died from their toxicities of therapy. So how do we improve these outcomes? Well, as mentioned, venetoclax is certainly an attractive candidate, but we think there may be ways to improve upon simple venetoclax therapy. So the M16-106 was an industry-sponsored adult and pediatric trial that combined venetoclax, the pure BCL2 inhibitor, with navitoclax, which is a combination BCL2 and BCL-XL inhibitor, with a non-myelosuppressive backbone of dexamethasone, vincristine, and pegylated asparaginase. This resulted in a CR of some form in 9 of the 12 children treated, and 6 of those 12 were MRD negative. So 66% of the responding patients achieved MRD negativity with either 1 or sometimes 2 cycles, but almost all of those patients achieved their best response in first cycle. The CRC rates were slightly lower in adults, but the overall survival for this multiply relapsed and refractory pediatric population was over 60% at 12 months, really suggesting this therapy was likely to be active. Toxicities were very real, but were as expected in the context of relapse therapy, including half of patients having febrile neutropenia and 20% of patients achieving sepsis, or having sepsis rather. And a quarter of patients had high-grade thrombocytopenia, which is unsurprising both because of the context of the disease, but also because navitoclax has on-target toxicity to mature platelets, which are BCL-XL dependent. And prolonged neutropenia and sepsis were among the DLTs seen at that top dose. And St. Jude was a good participant in this trial. We enrolled several patients, and our experience is very much in line with the trial as a whole. So we felt there was really an unmet need, both because of the patient population, but also because that trial enrolled only 12 children. And so we thought it was further important to really test whether this therapy might be active in first relapse, and particularly early first relapse, and wanted to evaluate the toxicities in a larger pediatric cohort. Importantly, with so few patients, there are not yet identifiers of response that we can identify to help predict patient response. And so we wanted to do that and further assess this response with additional combinations. And so we developed the RAVEN trial, which really hypothesizes that that combination chemotherapy will improve MRD negativity rates compared to those historical controls, and that we can develop novel venetoclax combinations as consolidation that can be both well-tolerated and active. And so the trial design is here. And the primary objective really tests the effect of this block 1 therapy with dexamethasone, which has been modified from the R3 regimen to a more DI-like 7-day on, 7-day off, 7-day on regimen, then vincristine at 4 consecutive doses, and either 2 doses of pegylated asparaginase or now in the US 1 dose of calaspargase, with a 22-day cycle of venetoclax and a 20-day combination with navitoclax. Dasatinib is added for patients with Abel-class fusions, and based on data from Jun Yang's lab, for patients with T-ALL as well. And the primary objective is really the end of block MRD negative rate, for which we've been very excited about results in our first 20 patients. But then we also wanted to test novel venetoclax combinations, and so I mentioned the importance of consolidative therapies. And so for patients who are CD19 negative, and these include both T-ALLs, but importantly, an increasingly growing population of patients with B-ALL who have relapsed after 19-directed therapy, we take half of the R3 and block 3 backbone, which is a high-dose cytarabine-based regimen, and give that in the context of dexamethasone, asparaginase, and a week of both venetoclax and navitoclax. And this is a first-in-human combination of venetoclax, navitoclax, and high-dose cytarabine in this population that is truly underserved. In contrast, if patients are CD19 positive, we combine blinatumomab with venetoclax, knowing that blinatumomab is our standard of care for patients with 19-positive relapsed ALL, and knowing data that venetoclax may improve the sensitivity of blinatumomab, and I'll show that data now. So here's quickly the combinations for Block 2A, again, a high-dose cytarabine regimen. We are continuing to enroll in dose level 1, and there's a dose de-escalation if we see multiple high-grade AEs. So far, this regimen's been well tolerated, and we're excited to continue to enroll patients on this. All right, and then dive in a little bit into the blinatumomab. I think the data that demonstrates that blinatumomab is standard of care for 19-positive ALL is well known, and I won't dwell on this given our time limitations, but both data from the US previously and now the Europe shown here suggest that blinatumomab is superior to intensive combination chemotherapy for patients with 19-positive disease. Why do we think venetoclax may help in the context of this therapy? Well, we know that effector T cells are largely resistant to venetoclax, and I'll show that data on the next slide. There's also data from preclinical CAR T models suggesting that venetoclax may enhance cellular cytotoxicity in the tumor microenvironment, and viral-specific cytotoxic T cell killing can also be further enhanced by venetoclax. There's data suggesting that venetoclax enhances the cytotoxicity of the CD20-CD3 bispecific drug epcoritamab, and venetoclax may selectively reduce regulatory T cells, and high levels of regulatory T cells have been linked to poor blinatumomab response and blinatumomab treatment failure. And so the combination of these 5 data points, along with some early data suggesting this might be well tolerated in just case reports of adults, let us move forward with this therapy. So here's some of that data that looks at the maturation-specific sensitivity of T cells to either venetoclax, ABT199, or navitoclax, ABT263. And this demonstrates that these older populations of T cells tend to be more navitoclax sensitive or navitoclax and venetoclax resistant. And because these effector T cells may survive venetoclax therapy, combined with the data that venetoclax may improve outcomes such as in these CTLs and in preclinical CAR T models, we combine venetoclax and blinatumomab. The blinatumomab therapy is standard therapy, meaning either a ramp up for patients with high burden disease or jumping right into the full dose for patients with MRD level disease. We provide dasatinib for able class fusions, and then venetoclax begins on day 8 and continues for 21 days. And this again was a dose de-escalation study. We were able to fully enroll dose level 1, and that dose level was well tolerated, and we saw impressive responses in the few patients that came into that after being MRD low at the end of block 1. And so we're continuing on with the dose expansion in this patient population and are quite excited with how things are going. And so the summary for ALL is that conventional therapy will leave most patients with relapsed ALL with residual MRD after block 1. And venetoclax and navitoclax combination therapies are promising in the limited numbers that we're seeing in the phase 1 study. Our RAVEN protocol is further evaluating this combination as reinduction therapy and is also evaluating those 2 novel therapy combinations as consolidation. This trial is currently rolling in St. Jude and will be opening soon elsewhere in the US, as well as with AMSCHOG in New Zealand and Australia. And so I think we've got a lot of future exciting directions, certainly with the potential outcomes of the trials that I've mentioned to you. But I think that the ability to identify biomarkers and to identify predictors of response is even more important in many ways, and is one of the things I'm really excited to see from these coming trials. And so looking at that window response in the context of APAL 2020D, there's also in vitro drug sensitivity testing and BH3 profiling occurring as part of that trial, and we hope that those will also prove to be useful biomarkers. But critically, we're going to have almost 98 patients or almost 100 patients, and we're assessing the genomics in this large cohort and trying to correlate that with venetoclax response as well. In the context of RAVEN and relapsed ALL, we are doing both genomics and pharmacotyping or in vitro drug sensitivity testing, and believe that this will provide important information about patients that might be successfully treated or patients that might be better served with alternative therapies. And there's several additional correlative biology studies occurring that will help us understand some of these novel combinations as well as the relapse therapy as a whole. And so this is the work of a whole lot of people. I've included primarily the clinical folks, but there's a lot of lab folks here and our support that are really helping to make these trials possible. There's been support from the Leukemia Lymphoma Society, both for me as a PI and for the trial as a whole for 2020D, as well as Princess Maxima. and support from St. Jude for Raven. I did not include support for other research that occurs outside these discussions, but I'm grateful for that as well. And thank you all for the chance to talk today, and Jeff for your introduction.
Seth, that was a great talk and great kind of overview and summary of all of the work that you've been leading. I don't see any questions in the chat yet, but I will get things started. And so, you touched on this a little bit at the end, this concept of biomarkers and predictors of response. And, I was wondering if you could expand a little bit more in terms of whether or not you think that there are going to be kind of genetic determinants up front that would predict response, or are we going to be able to, are we going to be predicting things in that way, or is it going to be more after treatment and then using biomarkers to predict response? If that question makes sense.
I think it does. I mean, I think what I expect to see in the combination of venetoclax therapy is somewhat the pattern that we see in leukemia more broadly, which is that we can identify genetic subgroups that appear to be more responsive to either therapy broadly or different subsets of therapy. And that there will always be outliers in those populations. And so there are prior data that suggest, for example, that some KMT2A patients might be more sensitive to venetoclax therapy. Obviously, menin inhibitors are on the horizon for those patients as well. But we know from our own clinical trial experience and our clinical experience with those patients that some of those patients are resistant. And so I think what will be really exciting is as we get larger and larger populations, we may be able to identify these secondary lesions that within a population that you might expect response actually gives us mechanisms that drive towards resistance or give us reason to believe those patients might not ultimately respond. I think we'll also hopefully find that if we're able to do sequential genomics for some of these patients, that we may see emergent genetic changes or emergent epigenetic changes that are driving resistance that may give us further pathways for treatment.
Okay. I'll ask a follow-up question in terms of biomarkers. I mean, do you think, we're collaborating actively on BH3 profiling, and do you get a sense for, is it going to be BH3 profiling or some version of that, or what role does kind of expression profiling of the various targets play a role in kind of, some of these follow-up studies and predictions?
Yeah, it's an area that we're actively testing. I think that what we have learned from prior studies is that gene expression of just BCL2 or just one or two members of the family is really not predictive. And I think that one reason that BH3 profiling so far has appeared to be better is that it really gets more at a broad swath of some of these markers and is better able to assess the balance between the various proteins that are occurring at the cellular level. I think what remains to be seen, at least for me in the context of pediatric AML, is whether if we do much broader gene expression profiling across the entire family, whether that actually turns out to be a little more predictive than looking at single members. I think so far, just looking at BCL2, for example, has not really been very helpful, but we will continue to look. It's an area that everyone is obviously very interested in. Gene expression profiling is a lot more widely available than is BH3 profiling. And in the context of something like comprehensive tumor genomics, you may be able to pull that data out of, for example, RNA-seq. And so you can imagine there are ways to get at that data if it turns out to be useful. And if not, then we'll have to rely on BH3 profiling or something even in vitro or in vivo.
Okay. I do have a question in the chat now about the role of venetoclax in maintenance therapy for ALL.
I think it's an interesting question. We have not done a lot of work combining venetoclax with the big drugs of maintenance therapy, for example, 6-MP and methotrexate. Venetoclax appears to be synergistic with almost everything in vitro, and the reason for that is presumably because all chemotherapy provides some level of cellular stress and is pushing those cancer cells towards apoptosis. And so when you take away some of the brakes, sort of cut the brakes in leukemia using venetoclax, then the cancer cells are more likely to die. But I think we don't yet know whether venetoclax would be beneficial in that context. I think we know that it appears active in the cancer very broadly, but I'm not sure we are yet ready to add it to something like maintenance.
Okay. And another question, someone is asking about whether or not there are external factors, whether it be, predisposition, family history of cancer, or just other external stresses that are known to influence the response to venetoclax.
Yeah, another really important question, and I think one that we are going to take some time to have to get to, meaning only that until we treat more patients, we're not going to have enough patients with things like family history or cancer predisposition syndromes who have received the drug to let us really understand whether those patients are more likely to fail venetoclax treatment. We absolutely think that it's important to gather information like that as we do these trials so that we can further understand those things in the future.
Okay. And final question, since we're almost at the hour, is there any role in venetoclax for primary ALL or AML induction in maintenance therapy? So, somewhat similar to what we asked earlier, but now looking at kind of upfront induction.
Yeah, I mean, I think we all suspect that is where the field is headed. Certainly the AML 23 trial, which just opened at St. Jude and will open it at some of our collaborating sites over the next year or so, is asking that exact question. If we combine venetoclax with standard frontline AML therapy, are we going to improve outcomes for patients at frontline and therefore prevent relapse and really prevent the need to come back to these drugs later? I know Dana-Farber is running a trial of or is planning to run a trial in the very near future of combination venetoclax and frontline ALL therapy, and we plan a trial in a subset of T-ALLs that we think would be venetoclax responsive. And so I think we hope that in 5 years we'll really know some of these answers, but all TBD.
Gotcha. Okay, well, it's the top of the hour, so I'd like to thank Dr. Carroll and Dr. Crompton for their wonderful talks today, and we're going to close the official event now. But anybody that has additional questions or wants to, further engage the speakers, please stay on for a continued discussion in an extended Q&A session. And before everyone logs off, I also just wanted to mention that to please join us next week on August 24th when Dr. Ben Greenbaum will be presenting on translating the self-non-self discrimination problem in cancer. So thanks again to the speakers and for everyone for attending today. Okay, Lily, you are still on as well, and so I think we've addressed all of the questions in the chat. I mean, so I do have more questions. I don't want to hog everything. So Brian, once again, really great. I mean, obviously this is something that all pediatric cancer centers are talking about and trying to understand how to move things from research to clinical. And so, what have your experiences been there in terms of trying to develop a test that can be used in real time clinically, especially in terms of sensitivity, like, how low do you need to go and how low is really relevant? It's kind of two questions there, so I apologize.
Yeah, it may be more than two, actually.
Yeah.
I think what's challenging about it, answering that question is it depends on the question you're asking, right? It depends on what the clinical indication is. So if it's pre-treatment prognostication, I would say it's more important that you have a good turnaround time than you get super sensitive, because what it seems like we're finding so far is that high versus low matters, right?
Yeah.
And so if you have a threshold that's around that cutoff between high versus low, you don't need to be super sensitive. But for MRD detection, if you're looking for residual disease when the patient radiographically has, no evidence of disease, you need like incredible sensitivity, right? So those are probably totally different assays.
Yeah.
Beyond that, though, if you let's say you just take the diagnostic piece, if you look around at the commercial assays, that are available, a lot of them are oriented around point mutations that our tumors almost never have, or certainly don't have at a high rate. So I think it's a really difficult question to answer because this field also is evolving so quick. There are a lot of companies out there that are actually not even public yet that I think we don't even know about, who are developing tools. Nobody really knows if methylation versus profiling is going to be the way to go for both diagnostic and early prognostication. That I think it's hard to answer. So one of the ways we're trying to tackle this is that with permission from Doug Hawkins, we put together a task force at COG to really think about where we're going to go with return of results. And honestly, one of the first questions, is we invited, people who have labs focused on liquid biopsy, people, but importantly, we invited a lot of investigators who are running trials at COG and outside of COG, because I think the first question we have to tackle is, what is the problem people want solved first? Because then we can think about what's the assay that solves that, and is it a pan pediatric assay, or is it like a couple of assays across a few different cancers? So I think like it's going to take more than just what I think, and that question being asked for us to answer that question. So I think having, there's probably about 30 people on that committee. I think we'll try to digest those questions over the course of the next year, and then head off in a couple of directions. That's how I think we're going to solve this problem.
Yeah. Yeah, and I worry a little bit that, for the MRD question, I think is going to be really tricky, because the clinical grade analytical pipelines are not quite ready for kind of going down to the levels that I think a lot of people need. So there's a lot of kind of behind the scenes pipeline development that needs to happen.
Yeah, and my personal feeling is I doubt that that's where we're going to start.
Yeah, no, I agree.
No,
yeah.
but I think some of these off-the-shelf assays where we don't have to customize things, or we don't have to do like patient-specific panels or patient-specific breakpoints, will give us pre-treatment and then early on treatment. I mean, we won't get MRD level probably right away, but you can see from some of the plots I showed, there's a handful of patients who, after a cycle of therapy for Ewing, definitely osteo, rhabdo, neuroblastoma, they don't clear their ctDNA, even using these low sensitivity assays. So that's got to mean something. I think that means something. I think that means those patients are probably already in trouble, and we need to change therapy for them early.
Yeah.
Do you think the same thing is true at diagnosis, Brian? I mean, you showed that graph that, the neuroblastomas tend to have much higher, but I mean, I guess I'm curious what you think of that, because I would think that osteos, for example, would have a ton, and they're quite a bit lower than that. So,
I'm not surprised they don't have a ton, because they don't have, as far as we can tell, a ton of circulating tumor cells. So there's no doubt, I think ctDNA gets shed from primary tumors, but I think what happens in a lot of these cancers that are more metastatic and potentially have a higher burden of circulating tumor cells leading to those metastatic samples is that, CTCs peel off, and probably some very small percent of them are fit enough to survive circulation and setup. The rest are apoptosin in the blood. And I think that's where a lot of our cell-free DNA gets shed. So Ewing, you can have bone marrow disease, right? Neuroblastoma, the first sequencing studies of neuroblastoma, they filtered out in the high-risk population all the variants from the tumor sequencing, because there's so many CTCs in the germline sample, and they didn't know that it was filtering out all the variants. So these are like diseases where there's a high amount of like bone marrow involvement and circulating cells. So I think that's where a lot of it's coming from, and I didn't expect that in osteo. So I think that's why the levels are lower at diagnosis. But then you can see like it's a less chemo-responsive disease, right? So you see a lot more variability in how quickly it clears, and the clearing happens slower. So all of it's lining up with what we experience clinically. So I think that means we're going to be able to sort of use all that data to make informed decisions. One of the other questions that also often comes up after that is, so what? When we have tried intensifying therapy more for osteo, it hasn't really worked, but we've never really done it early, and we haven't done it in a very refined way. And I just keep pointing back to the ALL story over and over again. MRD and in the early days, all that meant was intensifying with more chemotherapy, right? Now we're obviously, as you showed, Seth, in your beautiful presentation today, it's getting more sophisticated. You have bites and all this other stuff, but back in the day, they drastically improved outcome for that really horrible outcome group just by intensifying chemotherapy early on for patients with poor MRD. So I just think that we haven't tested that at all in this sophisticated way, and it's a shame not to. The last piece I'll add to that is, what about patients who were cured back with VDC for like half the time when we first started treating Ewing sarcoma? Literally half of patients were cured with just VDC. Now we've added IE, now we're interval compressing, we're going long. like all that's toxicity, right? So why can't we find super low risk patients, small localized primary, no STAG2, no P53, and low ctDNA diagnosis? We should be thinking about dose reducing for those patients eventually. Like we haven't proven that yet, but I think this data that we're generating is on the cusp of finding potentially a low risk cohort where we can start doing. I mean, they've done this in Hodgkin's lymphoma, they've done this in Wilms tumor, neuroblastoma. De-intensifying for our low risk patients is really important. So we shouldn't forget that aspect too.
Okay, let's give Seth some questions. And so a few questions for you, Seth, about pediatric MDS. And so do you see a role for Ven and Ven-Aza in the treatment of pediatric MDS?
Yeah, so as I dropped in the chat, I think there likely is. I don't think we have great data for it yet. There are certainly case reports or even a few, I think, small case series that look at the efficacy of Ven-Aza in MDS-associated pediatric AML, and it looks very active, looks very encouraging. The adult data for AML broadly and AML, including MDS-related AML, looks really encouraging. I mean, that's really where venetoclax shown first in adult AML is in the more smoldering AML that adults tend to show that they would previously treat with just AZA. The addition of venetoclax really is very effective in that group. And so whether you use it to try to get patients into something resembling a remission prior to transplant, whether you try to clean up the bone marrow with a transplant and then give them some kind of maintenance with Ven-Aza after transplant, I think people have tried both approaches. We don't even know which of those is right or if any of them really help, but I strongly suspect that some combination of that is active and useful.
Yeah. And then kind of along those lines, a follow-up question is, using just the reduction in blast percentage, is that, how universal is that going to be, especially to some diseases with low blast counts?
Yeah, I think the ones that have low blast counts are a lot more challenging, frankly. I think we don't know is the short answer, and I would say that we don't yet have validation that that's the perfect biomarker. It makes the nice thing about it is it makes a fair bit of sense. Like with every other sort of MRD-based assay, it's really a reflection of how easy your cancer is to kill with the drugs that you're using. And so, if you've got data that your cancer is responding well quickly, that suggests that you're more likely to get a response. And so you could do serial bone marrows if it was going to change your management. But I think in something like pediatric MDS, your goal is to get them better and then get to the transplant. And so you might be marrowing just to figure out if you're ready to go to transplant, if you want to try further therapy. And I think that might be a rational way to try to use it. But I wouldn't use it to change management at this time.
So Brian, another question that has come up, and you largely touched on it, and so if you don't have anything else to comment, that's okay, but it deals with screening for patients with a predisposition.
Well, I think, the only thing I would add to what we said previously is, I do think patients also have to be cautious about how some liquid biopsy assays are getting commercialized and marketed. So, Grail is a well-known liquid biopsy group and company, and they focus on their goal is to do early detection. They use a methylation based approach, and they're sort of marketing it without FDA. They're more than sort of. They're completely marketing it without FDA approval. In fact, they failed to get early FDA approval based on some of their early data. To take it a step further, in the patients with Li-Fraumeni syndrome, for example, we know from David Malkin's work that their white blood cells have a different methylation pattern because of the P53 variant. These are non-cancer white blood cells, have a different methylation pattern than patients who don't have LFS. And so the methylation assay that Grail focuses on is looking for differences between methylation patterns of cancer cell-free DNA and normal cell-free DNA, which is actually the most abundant cell-free DNA, even in patients with high burden of disease. So if the baseline's different, like how's that going to skew their ability to detect cancer? Is it going to lead to tons of false positives or ton of false negatives? And yeah, we hear all the time, my clinic is cancer predisposition at Dana-Farber, and this comes up, like patients want to know, should we, shouldn't we? And we have zero data. And so to me, until we start like rigorously doing this in the cancer predisposition cohort, I think it's dangerous to start sending off these clinically available tests. I think that it would be crazy not to do studies in this. And as I mentioned, we are working on this in a couple populations, but I think we should be looking across all the pediatric relevant cancer predisposition syndromes.
Okay, that's all the questions that we have in the chat. Lily, do you have any further questions? And if not, we'll excuse everyone.
I think it was just great talks, guys, and I think, for Brian in particular, I think that the heterogeneity question is really interesting to me as well. So I hope you guys can make some headway there.
It's like the next 5 years of the lab is going to be so focused on deep profiling and serial studies. It's going to be, I don't know, mind-blowing, I think.
Super cool.
Okay. Yeah, great job, guys. And I look forward to interacting with you in the future, Brian. And Seth, I'll see you probably later today.
Good.
Thanks so much. I really appreciate the opportunity. Bye, everybody.
Okay.
Thank you, everyone. Great job, Brian.
You too.